Hello everyone. Welcome to Group 6's Outcome Measures presentation. Our group members are Annalie Kerr, Ben Rogers, Chandler Young, and Holly Hawkins. We will be explaining the 5-time sit-to-stand test and the knee injury and osteoarthritis outcome score, or KOOS. First, we will talk about the 5-time sit-to-stand test. This test is used to assess a patient's lower extremity strength. The test can be used by a physical therapist at an initial evaluation exam to see the current condition of the patient's lower extremity strength. This will help guide the physical therapist in an intervention program designed for that patient. The test is often repeated on a later date to see the patient's progress throughout the course of the treatment as well. This test analyzes the time it takes a patient to transfer from a seated position to a standing position 5 times as fast as he or she can. There are a few exceptions, but for the majority of the population, the patient should be seated all the way in the back of the chair with his or her back touching the backrest of the chair, hips at a 90-degree angle, and feet flat on the floor. The patient's arms should be folded across his or her chest to avoid the patient using the chair's armrest. Finally, the patient should stand straight up to where his or her knees are in 0 degrees of extension before sitting back down in the chair. The target populations for this test are patients ranging from 18 to 64 and 65 and older. There are also some common medical diagnoses in which it often is or may be utilized, and these are vestibular disorders, stroke, pulmonary diseases, Parkinson's disease, multiple sclerosis, joint pain and fracture, cerebral palsy, back pain, and arthritis. There are 2 areas of assessment for this test, and they are functional mobility and strength. The ICF domain is activity. It takes less than 5 minutes to complete this test. The only required equipment for this test is a standard height chair with a backrest and a stopwatch. There is no training needed for this test to be administered, and the test is free of cost. This test is scored on a range from 0 to 4, with 0 being the lowest and 4 being the highest. The patient stands up and sits down 5 times as quickly as they can when the therapist says go. Timing begins when the therapist says go and stops when the subject's buttocks touches the chair on the 5th repetition. The patient scores a 0 if they are unable to complete the test. They score a 1 if it takes longer than or equal to 16.7 seconds. They score a 2 if they're in 13.7 to 16.6 seconds. A 3 inside 11.2 to 13.6 seconds. And they score the highest score of a 4 when it takes less than or equal to 11.1 seconds. In researching this test, it was compared to activities, Specific Balance Confidence Scale, or ABC, and Dynamic Gait Index, or DGI, because these tests correlate well with each other. This can be discussed in interpretation of change over time, measures of reliability, test validity, and any other psychometric property of interest. In interpretation of change over time, slower sit-to-stand times have been related to balance disorders in older adults and greater deficiency of instrumental ADLs. Change in this test performance should exceed 2.5 seconds to be considered significant beyond measurement error. In measures of reliability, the interclass correlation coefficient of 0.89 was reported, which indicates good relative of the test reliability. Of the 2 physical therapists, each demonstrated good inter-rater reliability by recording plus or minus 1 second between each other. Test validity for this test displays concurrent and discriminant validity that can allow this test to be useful in clinical decision making. The concurrent validity of the test was determined using the Spearman-Rowe coefficient. The Spearman-Rowe coefficient between the test and the DGI was negative 0.8 with a p-value of less than 0.001, and between the test and the ABC was negative 0.58 with a p-value of less than 0.001 as well. Any other psychometric property of interest for the test is a more sensitive test to identify differences in younger adults with balance dysfunction than in older adults with balance dysfunction.
Hey all you cool cats and kittens. Today we'll be doing the 5-time sit-to-stand test, And so for this test, all you need is a chair and a stopwatch. So what you're going to do is you're going to have your patient sit in the chair with their back up against the back of the chair. You want their hips at about 90 degrees with their feet straight out in front of them. And what you're going to do, you're going to get them to cross their arms across the chest, right there, and they're going to stand up and sit down 5 times as fast as they can. There are just a few things you kind of need to keep in mind when you're doing this. Make sure that the chair is not stabilized against the back, up against a wall or something like that, as that could alter your test results. Make sure your patient, if you do have armrest for a chair, make sure they're not using the armrest for the chair or anything like that. And just keep that in mind as you're going through this test. You want to get an accurate reading for that. So what we're going to do now is we're going to have him stand up and sit down as 5 times as fast as possible. He'll start when I say go, and then I'll stop the stopwatch when his bottom hits the chair at the 5th time. Okay? So what we're going to do is I've got a stopwatch here on my phone, and when I tell you to go, you understand the direction, you have any questions? Good? Yeah. Okay. All right. You ready? Go. Time. Okay. So he had a time of 14 seconds and 14.71 seconds. So now you guys can tell me which category he falls into. That's it.
The patient had a time of 14.71 seconds for the test in the video, and we asked what grade would you assign based on his time to complete the test. You should have set a 2 because he was in the range of 13.7 to 16.6 seconds.
All right, next we're going to be talking about the knee injury and osteoarthritis outcome score. KOOS is a self-administered questionnaire designed to help evaluate short-term and long-term measures of function for people with a knee injury or osteoarthritis of the knee, which can help PTs in creating a treatment plan for their patients. This test is made up of 42 questions that analyze one of 5 different areas, including pain, symptoms, functions of daily living, functions in sports and recreation, and knee-related quality of life. Each question gives a statement and asks the patient to the extent to which he or she agrees with the statement given. At the end of the questionnaire, the test assigns a total score to each of the areas of life and compares it to the normative data or previous data collected by the same patient. The target population ranges from 13 to 79 years of age. Some common medical diagnoses that KOOS often utilizes include a knee injury that results in post-traumatic osteoarthritis, an ACL injury, a meniscus injury, a chondral injury, ankle and foot problems, hip problems, or RA and other inflammatory joint diseases. So once again, this test was developed to assess the patient's opinion regarding their knee and associated problems. The ICF domain of this test is body function and activity, since it asks questions regarding knee function as well as the knee's response to activities of daily living. The patient should be able to complete the questionnaire within 10 minutes. The only required equipment to complete the test is a printed out copy of the questionnaire and a pen. The administrator needs no prior training to give the test, and the cost of taking the test is free of charge. The KOOS questionnaire is scored on a 5-patient relevant subscale, which are scored separately. There are 9 items in the pain section, 7 items in the symptoms section, 17 items in the ADL section, 5 items in the sports and recreation functions section, and 4 items in the quality of life section. Each item has 5 possible answer choices that are scored from 0, meaning no problems, to 4, meaning extreme problems. The scores from each section are calculated as a sum and are transferred to a 0 to 100 point scale. The scores are transferred using the equation located at the bottom of this slide. Once in the 0 to 100 point scale, 0 represents extreme knee problems and 100 represents no knee problems. The percentage of the total possible score achieved is represented by the score between 0 and 100. The next 2 slides show specific questions asked throughout the questionnaire. As you can see, there are 5 separate answer choices for each question. As the patient fills out the questionnaire, they read each statement and then respond as necessary. If you'd like, you can take a moment to read through the sections and see what type of questions the patient fills out. In researching this test, several subjects can be discussed regarding the interpretation of change over time, measures of reliability and validity in concern to the KOOS test. As stated earlier, the KOOS score is a percentage between 0 and 100, which is 0 represents severe knee problems and 0 represents no knee problems. First, we'll discuss the interpretation of change over time. The effect size varies depending on what procedure the patient underwent and the specific KOOS subscale. For example, the quality of life subscale is most responsive to change, and the pain subscale is the second most responsive to change. Also, the highest effect sizes obtained follow a total knee replacement. Overall, this questionnaire demonstrates a high level of responsiveness in effect size and standard response means of greater than 0.8. Next, we'll discuss measures of reliability. The retest reliability is sufficient enough to follow change over time. The KOOS demonstrated adequate clinical reliability with an interclass correlation coefficient 0.7 or greater. However, lower reliability was observed for the KOOS in sports and recreation subscale in both the Singapore English and Dutch versions, as well as the symptoms subscale. Lastly, we'll discuss test validity. Validity was evaluated by assessing content, construct, and criterion validity. Face validity is considered a type of content validity that cannot be statistically estimated. Criterion validity is indicated by the correlation coefficient that show the agreement of scores of new measurement with a gold standard measurement. For this review, a correlation coefficient of greater than 0.5 was defined as being strong. 0.35 to 0.5 is moderate, and less than 0.35 is weak. Physical functioning, pain, and the quality of life subscales tended to show strong correlation among each study, while the sports and recreation subscale commonly showed a weak correlation, and the pain and the symptom subscales occasionally showed a weak correlation among the studies reviewed.
All right, so what we're going to do today is the knee injury and osteoarthritis outcome score. And so this is just a self-administered survey that we're going to give the patient, and we'll give it to them now, and a lot of times the PT will give it to the patient later on to see how the PT treatment has been going. And so what you'll do is, here's your survey. You've got the questions right here, and then there's 4 different boxes. I want you to check each box as it applies to your life and how much you agree with that statement, okay? And then at the end of this, it'll compare 5 different areas of it, and then we'll be able to see where he's at now, and then be able to go back later and compare how far he's come throughout his treatment. So here's your pen. You have any other questions about how to fill this out?
No, sir.
No? Okay.